Today we are going to see about thyroid carcinomas. There are about 5 major types of thyroid carcinoma, of which first we are going to see about papillary thyroid carcinoma. The papillary thyroid carcinoma, it is the most common type of thyroid carcinoma. It is more common in females. Overall, thyroid carcinoma is also more common in females than in males. The papillary thyroid carcinoma, it is also more common in females. It is more common in second and third decade of life, and it carries best prognosis among the major thyroid carcinomas. The risk factors, the important risk factor is the radiation exposure to the neck. In the adolescent age group, for Hodgkin's lymphoma, radiation is given, and these patients are more prone to develop papillary thyroid carcinoma. So radiation is an important risk factor for papillary thyroid carcinoma. The long-standing thyroglosal cyst also predisposes to papillary thyroid carcinoma. Cowden syndrome is also involved. The most common gene involved is BRAF gene. This BRAF gene mutation causes papillary thyroid carcinoma. Clinical features: the patient presents with a thyroid swelling in front of the neck. Also, the patient can also present as lateral aberrant thyroid. What is this lateral aberrant thyroid? This is the patient may present as only the node, the cervical node alone is enlarged with an occult thyroid. There will be no palpable thyroid swelling will be seen. Only the cervical node will be enlarged. This is lateral aberrant thyroid. The most common site of lymph node metastasis is the level 6, that is the anterior group of nodes. It is otherwise called as a Delphian nodes. So, it mostly spreads via lymph nodes than hematogenous spread. The most common spread is lymph node. In that, level 6 is most commonly involved. In the distant metastasis, it spreads to the lungs. The diagnosis is done by FNAC. It is a hormone dependent tumor. So, the TSH level in this tumor will be very high. On FNAC, on pathology, we can see orphan Annie eye nuclei. The orphan Annie, it is a cartoon character where there will be no pupil and iris. Inside the eye, there will be no pupil and iris. It will be blank. The similar type of blank nuclei, that is clear nuclei, will be seen in case of this papillary thyroid carcinoma. So it is also called as orphan Annie eye nuclei. These papillary thyroid carcinoma also present with samoma bodies. What is the samoma bodies is? They are this concentric calcification. This concentric calcification is called as samoma bodies. They are also seen in meningioma, serous cystadenoma of ovary, serous tumors of pancreas, renal cell carcinoma, and prolactinoma. In 6 places it is seen. One is papillary thyroid carcinoma. Then next one is serous tumors of the pancreas and also ovary, also meningioma. In meningioma also it is seen. Prolactinoma and renal cell carcinoma are also in these places also samoma bodies is seen. What is the management? The management, if the patient is having a 1 to 4 centimeter sized tumor, if it is a unifocal tumor, if there is no capsular invasion, and if there is no lymphovascular invasion, then we can proceed with hemithyroidectomy. What is hemithyroidectomy? Hemithyroidectomy, the thyroid has 2 lobes. In this hemithyroidectomy, we are removing only the affected lobe along with the isthmus. The isthmus, the central part, along with the affected lobe is alone removed. This is called hemithyroidectomy. If the patient fulfills all these 4 criteria, 1 to 4 centimeter size tumor, unifocal, no lymphovascular invasion, and if there is no capsular invasion, then we can proceed with hemithyroidectomy. One exception is that if the patient has a history of radiation exposure, there is no concept of hemithyroidectomy. Directly we have to go for total thyroidectomy. So in all the other cases plus this radiation exposure cases, we are performing total thyroidectomy. If the patient has papillary thyroid carcinoma along with this level 6 Delphian node is involved, then we do total thyroidectomy with central lymph node dissection. We remove this level 6 node. If the patient has papillary thyroid carcinoma along with this level 6 and also some other node, that 1 to 5, some other node is involved, then we perform total thyroidectomy with central lymph node dissection along with MRND. So now we have to see what is this MRND. MRND means it is modified radical neck dissection. Then first we have to see what is radical neck dissection. In this radical neck dissection, we remove all the 1 to 5 nodes, level 1, 2, 3, 4, 5. These nodes are removed along with the submandibular and parotid gland. It doesn't end here. It also removes spinal accessory nerve, sternocleidomastoid and internal jugular vein. Everything is removed in this case of radical neck dissection, and this patient had many complications post-op. So they have modified this modified radical neck dissection, and there are three types of modified radical neck dissection: type 1, type 2 and type 3. In type 1, one of these three structures is preserved. In type 2, two structures are preserved. In type 3, three structures are preserved. So one structure we are going to preserve. So I have to preserve the most important structure. The most important structure among this is the nerve, spinal accessory nerve. In MRND1, spinal accessory nerve is preserved. In MRND2, the nerve and the vein is preserved. And in MRND3, all these three structures are preserved. So it is also called as functional neck node dissection. Next, after performing the surgery, we have to follow up the patient. Follow up the patient for any metastasis or else any residual diseases are present. We have to follow up this patient. For this, we have to do a whole body iodine scan. The whole body iodine scan. Before performing this whole body iodine scan, we have one prerequisite. And it's that the TSH level must be more than 20. We have to make the TSH level more than 20. For making this level more than 20, we have two methods. One is the traditional method and other one is the recent method. In traditional method, what we do is we make the thyroid tissue, any residual tissue or any metastatic tissue that is remaining, we have to make them starve for iodine, so that when we give this iodine scan, when we perform this iodine scan, they will go and attach to that cells and we can identify the metastasis as a residual disease. But for this we have to wait for 4 to 6 weeks in case of in this traditional method. What we do is we don't give thyroxine for this patient, so that these cells, they starve for iodine. They starve for this iodine, and for 4 to 6 weeks we wait and we make the TSH level more than 20, and then we perform the whole body iodine scan. The another method is now it is used is the recombinant thyroid stimulating hormone. We give the recombinant thyroid stimulating hormone from outside and make this level 20 and we perform this. This can be done immediately. But for the first traditional method, we have to wait for 4 to 6 weeks and then we perform the whole body iodine scan. After performing the scan, there are two possibilities. One, if there is any residual disease or metastasis is present, what we have to do is we have to do radioactive ablation. The iodine 123, it is used for diagnostic methods, and 131 it is used for therapeutic methods, therapeutic procedures. So this 131, its lifetime, its half-life is 7 to 8 days. So we are ablating them with the help of radioactive iodine. Suppose if there is no residual disease or metastasis, then good enough. We have to do lifelong follow-up. For this follow-up, we want some marker. We have to see whether there is any recurrence. So the marker that is used is the serum thyroglobulin. We have to see the level. If the level is more than 2, then we have to suspect a recurrent disease. 1. Then we have to do annual USG neck to have to see if there is any residual or any recurrent diseases are there. We have to see. Also, we have to suppress this TSH level. This TSH level has to be suppressed for lifelong by giving thyroxine. It is given as 300 micrograms. Supplemental dose of thyroxine is 100 micrograms. 100 micrograms is the supplemental dosage. But we are giving a suppressive dose. We have to suppress the TSH. For that, we have to give the thyroxine at the level into 3. We have to give 300 micrograms of thyroxine and we suppress the TSH level. Thank you.